ভিডিওটা টুইটার মুইটার কেন?
হ্যালো হ্যালো
হ্যালো, শুনতে পাচ্ছ?
হ্যাঁ স্যার, গুড ইভিনিং স্যার।
শোনা যাচ্ছে কিছু?
আচ্ছা, কোনটা দিয়ে কি?
হ্যাঁ স্যার, শোনা যাচ্ছে স্যার, আপনার ভয়েস শোনা যাচ্ছে স্যার।
এটা
ছবি ছবি
ছবি স্যার ক্লিয়ার।
হ্যাঁ ক্লিয়ার আছে স্যার।
স্যার অডিও ভিজুয়াল দুটোই ক্লিয়ার আছে।
দিস মিটিং ইজ বিং রেকর্ডেড বাই দ্য হোস্ট অর দ্য পার্টিসিপেন্ট, কিন্তু এটা তো হচ্ছে না, যাচ্ছে না তো, চেকেই যাচ্ছে।
স্যার ওটা গট ইট করে দিন।
আপনি গট ইট করে দিন।
হ্যাঁ ঠিক আছে ঠিক আছে ঠিক আছে।
আমার কথা শুনতে পাচ্ছ বিশ্বনাথ দা?
হ্যাঁ শুনতে পাচ্ছি। কেমন আছো?
হ্যাঁ ভালো আছি।
ভেরি গুড।
অনেকদিন পরে তোমাকে দেখলাম।
আর কি করা যাবে, কর্নার বাজারে। হ্যাঁ বলো।
ঠিক আছে, দেবাশিস দা এসছে মনে হলো না?
এক ঝলক তো দেখা গেল।
এসে গেছি।
দেবাশিস দা আছে।
হ্যাঁ গুড ইভিনিং গুড ইভিনিং।
গুড ইভিনিং গুড ইভিনিং গুড ইভিনিং।
ভালো আছেন তো?
ওয়েট হ্যাঁ বই চলছে, যে আপনি যা বললেন মোরালেস একটা জায়গায় আছি, একটা জায়গা থাকলেই ভালো।
সেই চলুক।
ঠিক আছে
শোনো, এদিকে ওই পেছনের পর্দাটা টেনে দে, ওই যে একদম পেছনে। ঠিক আছে, কোম্পানির লোকই এখনো জয়েন করেনি বোধ হয়।
করেছি স্যার। স্যার আমরা আছি স্যার, আমরা একটু ওয়েট করছি, সবাই জয়েন করেনি এখনো।
হ্যাঁ
नहीं चलते हैं सर क्या है सर हेडफोन का देखिए
সৌমদেব, হ্যালো,
হ্যাঁ স্যার স্যার জাস্ট আর 5 মিনিট
কি
স্যার
হলো মোটামুটি? আচ্ছা,
স্যার আর
করো।
জাস্ট 5 মিনিটস জাস্ট ফর 5 মিনিটস স্যার 5 মিনিটসের মধ্যে স্যার আমরা স্টার্ট করছি স্যার
হ্যাঁ, we are all fairly busy practitioner, end of the day, time
Yes, sir.
করা উচিত।
Your sound
না
is
তো-
very low, very low sound, sir. It is not audible at all.
Can you hear me now?
Yes.
Very faint sound, sir.
হ্যালো স্যার
হ্যালো,
হ্যালো
হ্যাঁ,
স্যার আপনি কাইন্ডলি একটু হেডফোনটা তুষার স্যার আপনি কাইন্ডলি একটু হেডফোনটা ইউজ করুন তাহলে স্যার হয়তো ক্লিয়ার আমরা শুনতে পাচ্ছি
কিন্তু
পরিষ্কার
এটাতে
স্যার।
আমি ইউজ করতে পারছি না হেডফোন। আমি অ্যাকচুয়ালি যে ফোনটা থেকে ট্রাই করেছিলাম সেটাতে আপনাদের এটা ক্লিক করলেও হচ্ছে না।
ওকে স্যার
ও, কারণ
স্যার আপনার কথা পরিষ্কার শুনতে পাচ্ছি।
আমার কথা শুনতে পাচ্ছ?
হ্যাঁ স্যার
হ্যাঁ, কারণ I thought my audio was quite clear. হ্যাঁ,
Yes,
Yes.
sir.
ওকে,
ঠিক বাবা আছে সেবা সে হাতে দেবো
প্রবলেমটা কোথায় হচ্ছে? প্রবলেম কোথায় হচ্ছে?
গুড ইভিনিং স্যার।
হ্যাঁ বলছি প্রবলেম কোথায় হচ্ছে?
না প্রবলেম কিছু নেই স্যার, আসলে আর দুজন বাকি আছে জয়েন করতে, সো আমরা কানেক্ট করেছি, সো স্যার উই আর স্টার্টিং। আই থিঙ্ক ডক্টরস, টু অফ দ্য ডক্টরস উইল বি জয়েনিং।
আমরা
হ্যাঁ স্যার,
আস্তে শুরু করি and they can join us.
yes sir, yes sir.
All of us
Always.
are busy and there has to be a respect of time.
Yes sir, yes sir. So with your permission sir, starting this program, sir, first of
Okay,
all,
thank you.
good evening everyone, every doctors,
evening.
respectable doctors. I am Sanjay, I am a RBM of Vitalis 4 and I welcome you on behalf of CIPLA. Thank you everyone for joining the session, and this is a CIPLA initiative to percolate heart failure knowledge right from the basics to the recent therapy among all healthcare professionals. And today we are here for this expert summit program. Basically, this is a strengthening heart expert summit, and this is a advert type of program. And we are having with ourselves our moderator, Dr. Debasis Ghosh sir. Nothing to introduce sir, but still I want to say something about sir. That sir is a senior consultant and Department of Interventional Cardiology and Chief Federation of Examiner for MRCP UK, and sir is also faculty of DNB programs and attached with Apollo Clinicals Hospital. So thank you sir for giving your valuable time for this program. And we are also having with ourselves, starting from Dr. Subhasis Ganguly sir as a panelist. Sir is a renowned physician and attached with Jane Roy Hospital. We are having with ourselves Dr. Vishwanath Chakraborty sir. Sir is having private practice of Central Kolkata. And we are also having with ourselves Dr. Somnath Mukherjee sir. Sir is renowned physician from and having a private practice from Baruipur. We are having with ourselves Dr. Tushar Kanti Bagh sir. Sir is physician of Susrusa Nursing Home of Kakurgachi area, and also sir is a very renowned physician of Calcutta. We are having with ourselves Dr. Bodhisattva Choudhury. Sir is attached with Parkview Hospital, Salt Lake, and Dr. Moinak Gupta sir is also in this program. Sir is attached with Amri, Salt Lake, ILS Damdam, and Charnock Hospital. We are having Dr. Sayan Gupta from North City Hospital, and Dr. Tonuka Mondal from Madam is attached from RG Kor Hospital. So thanks to all of the doctors for joining this session. So before I hand over the session, I request Dr. Debasis Ghosh to take this session and moderate this session accordingly. So thank you sir, thank you once again, and over to you sir.
Okay, thank you for those kind introduction, and it's a pleasure to meet everyone in these kind of forum. Basically, it will be a basically informal discussion on concentrating in heart failure management with special attention to mineralocorticoid antagonist, which is often what I feel an underused drug. And I think we will talk about our reservations. There are reservations about it, and we should be very frank. What are we afraid in our practice? So with these few words, let me share my screen to set the ball rolling. So we will.
Sir, sorry to interrupt. Just for a 1 second, sir. Requesting all of the doctors to please keep their camera on, so that sir, it is one of our compliance issues. So we have to keep this.
Okay.
So if there is no issue, kindly please keep the camera on, so that
Actually, I am Dr. Tushar Kanti Bagh. I have facing the sound issues. That's why I have to put my phone in
no issue,
near
no
my
issue.
Okay.
Okay.
Okay, sir. Thank you very much.
Also, the other one of the housekeeping sort of protocols we use in these meetings is to, when one of us are speaking, the others stay mute. Then the voice clarity is very, very good. Otherwise, if the voice, all the voices, microphones are on, sometimes there's a lot of extraneous sounds. So let me sort of start the discussion today, and I hope my A is visible. Is my slides visible?
Yes, yes.
Yeah. So I'll go on to a slide mode first. It's on a full slide mode, I hope.
Yeah.
Okay. So basically, we are, as I said, we will be discussing middle corticoanatomic rest and its relevance in heart failure. This is, as the CIPLA companies have said, is an advisory board, and it's not exactly a promotional purpose. And this is the meeting. So, what would be our objective? Where do we place MRAs in our utilization in heart failure management? We are often skeptical and we are uncomfortable with hyperkalemia and renal function, especially when we are using MRAs. And this is really a concern. Is the concern too overcautious, or actually it is a reality and we need to be really, really very cautious? And also we need to really, I sincerely think it's an underused, relatively cheap drug, which actually has a lot of evidence to prove that it is useful in heart failure. So this is just to set the context of the meeting. Heart failure, whether it's with whatever category it is a fairly prevalent disease, and with the aging population, it will grow more and more. So 1% of the population in India, if you look at it, that's the worldwide, it's 8 to 10 million individuals who will have heart failure. And I think in any busy clinical physician's practice, you will get at least 2, maybe 3 heart failure patients of varying per day, if not a little bit more. So here is the first sort of exploratory questions which we might diagnose. So basically, what percentage of heart failure come to you in NYT 2, 3, and 4? And do you feel that heart failure patients goes undiagnosed in India at an early stage? And what reason? And I think we can start with Dr. Vishwanath Chakraborty. Would you think, what in your practice, what stages of heart failure patients do you usually come across? When they come to you, which stage they are commonly there? Dr. Chakraborty,
Sorry. Can you hear me?
Yeah, I can hear. You're clear.
At times, it is causing. Yes, sir.
So, if you look in your practice, what phase or what stage of heart failure do these patients, most of your patients, come in, early or late? Which is
Actually, you see, basically, I do a general practice, maybe a medicine practice. So, acute patients we see more with a frank failure or just the symptoms of tiredness, shortness of breath and walking. Stage maybe NHY classification, stage 2, stage 3.
Yeah.
So such group of patients we see more in the practice.
I think I would agree. When we see morely in stage 3, 4 is too sick to be out in the community.
4 is
too sick to be in, 4 actually they are in the hospitals.
Exactly.
And stage 2 is very early, and that is where we need to initiate treatment. Stage 3 is the commonest, I think.
Yeah.
Dr. Ganguly, would you agree with that?
Yeah, I also agree with the same what Dr. Chakraborty told me. But in our chamber, we usually get so many patients who comes with hypertension, diabetes, obesity. They have a silent heart failure state or diastolic dysfunction, which while on examination and from the history itself, we can come to a conclusion that the patient may have got a diastolic dysfunction. And then once you go for the examination, so I think a group of patients, if you are seeing 10 or 20 patients, I think obviously around 1 to 2% of patients come with silent heart failure in the clinic also. But definitely in the hospital we see NYHA 3 or 4 class of patients.
I think I perfectly agree. Now, stage 2 is often very difficult to pick up because the shortness of breath, which is the main manifestation of heart failure, has so many causes. Dyspnea has so many causes. It's difficult to sort up in with just clinical examination unless you have improved tool and an improved protocol. Now, basically, what we'll move on to the next question. So, what do you think to make objective so that we can pick up heart failure patient earlier, before frank heart failure set in? Stage 3 and stage 4 heart failures, frank heart failure is easy to diagnose. You can straight away more or less diagnose it and you can go forward. So what are the diagnostic and prognostic tools you use to actually pick up heart failure, especially in the earlier part? Dr. Shambhunath Mukherjee, would you share your thoughts on it?
Yeah, thank you very much. So the diagnostic tool, especially for the heart class 1 or 2 is, first of all, every patient who comes with us with a shortness of breath, we go for an ECG. We see if there is a gross abnormality in the ECG. We have a suspicious that he might have a heart failure or something, some related to the heart ailment, this breathlessness or the dyspnea. Then the X-ray, and the most important test which we go for is echocardiogram. So that helps us a lot with the diagnosis, and the prognostic tools are later the blood reports and all the other blood reports which correlates with this main diagnostic test like echo, ECG, and X-ray. So these things we depends a lot on these tests.
I think that is an excellent. So I think the Europeans, I'll show the next few slides, which I put it on my own accord, which might make it more objective to diagnose heart failure. Now, this is the ESC guidelines, which has come in into 2022. So for diagnosis of chronic heart failure, you need 3 things: symptoms of heart failure, signs of heart failure, and objective evidence of cardiac dysfunction, which we have actually included in our definition. So you start with what are the symptoms. The symptoms is fairly simple: breathlessness, orthopnea. PND is, as we know, is a little more specific than breathlessness of any called fatigue and ankle swelling. So these are what we call the typical symptoms of heart failure, not very specific, remember. There are many causes of these symptoms. And the signs, again, very difficult to pick up. These signs are only present when the heart failure is advanced, not in early heart failure. And I find that only when you go into stage 3 or stage 4 heart failure, you have the JVPs raised, the hepatojugular reflux, a gallop, and an apex sound. So how do we define it? So we have to have symptoms of heart failure. We have to have certain specific signs of heart failure. And then, as Dr. Mukherjee was saying, that we need to have some objective evidence of cardiac function. And he did mention the 12-lead ECG. The 12-lead ECG is a very simple but very important tool. If you have a squeaky clean ECG, no abnormality whatsoever, not even a left ventricular hypertrophy, not even a left atrial enlargement on the ECG, heart failure as a cause of dyspnea is unlikely. The statement is pretty strong. So if you have absolutely a clean ECG, no abnormality whatsoever, no ST changes, no T wave changes, no left atrial enlargement, low LVH, and you're dealing with someone with dyspnea, heart failure is unlikely. So it's a very simple tool, a 12-lead ECG. Then obviously what Dr. Mukherjee mentioned, the chest X-ray and an echocardiogram, much more specific. And now we have the natriuretic peptide, which helps us in the diagnosis of heart failure. So this is very important. So you need to demonstrate some objective evidence of cardiac dysfunction. So that is very important. So you have to have symptoms, you need to have some signs and some objective evidence of cardiac function. But in a heart failure, I think you need to also to look at comorbidities as well. So anemic, kidney function, very important, and electrolyte, thyroid, glycemic and lipid status, and now an iron status. So I think basically this is a nutshell, the ESC guideline of trying to put an objectivity into the diagnosis of heart failure. So what Dr. Tonuka Mondal, would you think these guidelines are going to be useful in your clinic?
Yeah, it is definitely very useful. I am in RGCAR, so we kind of get more of NHA in my HA classification of 3 and 4.
Yeah.
But each of these investigations we rigorously practice, especially in our hospital. And in my clinic also, I rigorously practice this. And especially in cases that we get, like in diabetes, patients are obese, having hypertension, I always tend to rule out this heart failure because it is a huge cause of mortality. So I always tend to sort this kind of patients out and give earlier treatment so that we do not progress into heart failure and lose this kind of patients.
Absolutely, absolutely spot on. And I think this is the way to approach it. So if you put an objective into your clinical diagnosis, I think you're going to pick up more cases. And I think this natriuretic peptide, which is now more or less quite widely available, has been a really boom. Even before you have a chest X-ray or an echocardiography, a natriuretic peptide done in the clinic often helps us. To be fair, one thing you need to be here, 20% of heart failure with preserved ejection fraction, mainly with the, I'll come to the classification briefly later, but with preserved ejection fraction, you will have a normal NT-proBNP. So that is something you need to be aware of. So let us move on. And so this is the classification. It's not a new classification. We have heart failure with reduced ejection fraction. The most easy to pick up, you have you need signs and symptoms and an echocardiography which says your ejection fraction is below 40%. And we have had very good therapy and very advanced therapies, very interesting developments with life-saving therapies in this segment. The other end of the spectrum is heart failure with preserved ejection fraction. Again, to diagnose that, as Dr. Mondal was saying, you need not only you have to have signs and symptoms, and echocardiography will say that your ejection fraction is more than 50%. So this is not very, very absolutely 100% sure that this is heart failure. So for that, you need to have basically an elevated levels of natriuretic peptide, or at least one other additional criteria for structural heart disease in the form of a diastolic dysfunction on the echo, or a relevant structural heart function, like now a left atrial volume is now being touted as one of the interesting part of preserved ejection fraction. And in between the two, we have the mid-range or intermediate range ejection fraction. So I think basically therapy is a little different. The outcomes are a little different, and the therapy is a little different. Like we have a lot of therapy in reduced ejection fraction, but not a lot in the preserved ejection fraction. That is evidence-based therapy. So having said that, this is the stage A. We now know that the heart failure classification is stage A heart failure, where there is a asymptomatic, no risk, no heart damage. But as Dr. Mondal was rightly saying, people with high failure in the community, which is hypertension, diabetes, ischemic heart disease. So they haven't had a heart failure episode. Their heart structure is fine, but they are at risk for heart failure. Then you have stage B, which is asymptomatic, but have signs of structural damage on the echocardiography, but they are asymptomatic. Stage C is one which we come across very frequently in our practice. Overt symptoms and also supported by evidence. And I think that is how heart failure management will progress. So basically, just to put in a context, once you have heart failure, your risk is extremely high for future events, hospitalization, as well as mortality. Now, this is a slide I picked up from the ESC again, which shows that if you have atherosclerotic cardiovascular disease and you classify them in a very high risk, their event rate is about 7%. So you have a very high, say, a diabetic with a MI in the past, but with preserved ejection fraction, no heart failure, the chance of a recurrent life-threatening event is 7%. Very high, and we categorize that as very high risk. This is for atherosclerotic disease without heart failure. But the moment you have heart failure, even if they are stable heart failure, you start with a risk of 10%. So that shows that if you put it into context, someone with heart failure episode are straight away in a very high risk group. So that is something which we need to be aware of. So we'll now come into slowly migrate into the management of heart failure. And basically what we need to do is slowly discuss our reservations about the heart failure. So this is basically the reservation we have when we use a mineralocorticoid antagonist. We need to be aware of the potassium and we need to be aware of the renal function. And so if we look at this, are these parameters, A, are they relevant, and how frequent should we test them, and how long should we keep on repeating? Say someone, you have introduced a MRA, you have tested initially, and then he's on treatment. And how frequent should you test these parameters? And I'll ask Dr. Tushar Kanti Bagh to share his thoughts on this. So once you have introduced an MRA, what are the things you want to look for? Obviously, potassium and creatinine. And how frequent would you look that for? How frequent would you check that? Dr. Bagh, can you hear us? Hello? I don't think Dr. Bagh is there. Dr. Chaudhary, Bodhisattva Chaudhary, are you there?
I am here.
Yes, I am there.
Oh, audible.
Dr. Bagh is also there.
Achha, so Dr. Bagh, I was asking you because I was not sure whether you could hear us.
I am audible now, sir.
Yeah, you are audible. Yeah. The question is
after starting an MRA, when we start, we should measure an baseline potassium and creatinine. And after 7 days, we should repeat it. And after that, we can repeat it after 2 weeks. And it is, if it all fine, then we can repeat every 3 months. Interval basically of potassium.
Okay. I think this is absolutely fine. So the main thing is, because we are using other potassium sparing drugs as well, like an ARNI or an ACE inhibitor, when you use an MRA along with it, the chances of hyperkalemia is somewhat increased. And I think it's an important molecule to be used, but you should be using it judiciously and with monitoring. And I agree with Dr. Bagh. After introduce someone who's on an ACE inhibitor and an MRA, I would actually test it a bit early, probably within 72 hours of initiating the drugs. Because sometimes you do have an abnormal sharp rise in potassium level, especially when you have an ARNI or an ACE inhibitor above. Basically, Dr. Chaudhary, would you agree to that? That we need to probably, after the introduction, especially with ACE inhibitors or ARB above or an ARNI above, do you want to delay it to 7 days or you want to check it a little earlier? Dr. Chaudhary, are you with us?
Am I audible?
Yeah, you are audible.
Yeah, I think we have to always check the baseline urea, creatinine, sodium, potassium, but after that, when we should check, it depends on the patient, what is the baseline kidney status, whether the patient is having adequate urine output, whether the patient is on class 2, the stage, NOH 2, 3 or 4, all what other medicines the patient is taking. All the parameters should be considered, and depending on that, we should check whether we should check it after 3 days or 7 days or 2 weeks. I think rather than having a rigid guideline, it should be variable from patient to patient.
Absolutely right. It should be patient tailored. And one
Yes.
way of actually of putting your interval. So once you have checked the initial part after introducing, I check it within 72 hours of introducing an MRA, especially with ARNI or ACE inhibitor aboard. And once that is stable and you are happy with it, my protocol is to check it as a simple rule that the GFR divided by 10, that should be your EIA. So if your GFR is say 60 plus, 60, 70, you should check it at least every 6 months. But if your say GFR is 40, you should check it every 4 months. Under 30 GFR, you should be very skeptical of using an MRA.
Yeah, so it's not recommended.
So that is one way of looking at it. If you have to protocolize it, so you should test it at least if the GFR is very, very good and you have the initial stability achieved, then I think you should test it frequently. It's a GFR, that's a fairly good formula to use. GFR divided by 10, that should be the number of months. So, and I think you should go on checking. You should be seeing this patient anyway every 3 to 4 months, even if they are stable. Okay. So let us go on to what is the indication of MRA? How strong is the indication of MRA in the management of heart failure in 2021 guidelines? Pretty high. If you see in patients with reduced ejection fraction, MRA is recommended to reduce the heart failure hospitalization and death. So it does decrease mortality. So that is one. And the indication of use is class 1. What it means that everyone with heart failure with reduced ejection fraction should have an MRA if there is no major contraindication. Okay, so the statement is very, very strong. The statement is not that strong if it's a preserved ejection fraction or a mid-range ejection fraction, because all the work, the RAILS trial and the FSS trial have been done on with people with reduced ejection fraction. Here, there has been some evidence, but evidence is not that strong. So it's a class 2B indication. So a little softer indication, especially in heart failure with preserved ejection fraction. So that is something we have to mind, and that is the importance of classifying your heart failure. So this is something we need to be really aware of. So let us now go into the discussion again, and basically, Dr. Ganguly, what percentage of your patient would you consider in reduced ejection fraction? Do you try to introduce MRA?
Just last
with everyone.
Just once more. In what percentage of patient?
A patient with heart failure with reduced ejection fraction in your practice.
Yeah.
Do you try to use an MRA? And is it with everyone, or you are selective?
Yeah. If there is no contraindication in giving MRA, so in reduced ejection fraction, I usually go for either spironolactone or eplerenone.
Yeah.
I try to give all my patients MRA.
Okay.
If it is below 30%, and I have to see whether there is any other issues where potassium can rise. So just apart from those patients, I usually try to give all my patients.
Okay, absolutely fine, because they are I'll go on to the next detail. Dr. Mukherjee, Shomunath Mukherjee, would you agree with Dr. Ganguly's practice that in reduced ejection fraction, do you try to use MRA in every patient of reduced ejection fraction?
Yes. We do. Yeah.
So you are aware that it is fairly important.
Very important, and we see the contraindication if we stop it.
Okay. What I like about MRA is that they have some drawbacks with renal function and hyperkalemia, but on the other hand, is one of the cheapest drug to use. Second, it is basically not very hypotensive. Like if you introduce a high diuretic on the top of say ARNI or an ACE inhibitor, the blood pressure drops quite precipitously sometimes. But with the MRA, on the other hand, is someone you can even use it very comfortably with a systolic blood pressure of 100, and you don't have to worry too much of the blood pressure. It does not lower the blood pressure, it gently lowers the blood pressure. That has been my experience. Dr. Mondol, Tanuka Mondol, would you agree with that in your practice?
Yeah.
It is a kinder drug on the sort of on the blood pressure.
Exactly, it does not have substantial and huge effect on the blood pressure of the individual it is being prescribed to. So for that reason, it is a favorite of mine.
Oh yeah. Now coming to the little bit more contentious issue of heart failure with preserve. So with reduced ejection fraction, we all agree that it is one of the foundational therapies, and we'll go on to the foundational therapies, just revise ourselves. But it is, and everyone agrees that we need at least to make an effort to introduce it in everyone with reduced ejection fraction. So that is more or less, I think, basically quite encouraging to learn that we all try to introduce this molecule. Now with preserved ejection fraction, the data is a little weak. But Dr. Bagh, what would you give in someone with a preserved ejection fraction? What are the drugs would you use which will actually help the patient? What do we have data for? Any thoughts on that, Dr. Bagh?
I use basically definitely diuretics.
Yeah.
If a patient is having a heart failure with preserved ejection fraction, also the comorbid conditions should be kept in mind, and BP should be within normal limit. And I think beta blocker also help to in this regard.
I think I partially agree with that. And Dr. Shayan Gupta, are you with us?
Yeah, we are there.
So Dr. Gupta, can you tell me your thoughts about what are the drugs? I think diuretics was very, very good. I think Dr. Bagh has hit the nail. You need to relieve symptoms first. So diuretics is something which you need to introduce initially to render the patient euvolemic. But unfortunately, loop diuretics does not improve hospitalization or decrease mortality. Unfortunately, that is the truth in all the trials. So in a long term, once you have controlled the symptoms, with preserved ejection fraction, what are the drugs you would think of?
I would rather go for, other than this decongestive therapy in the form of diuretics, I would rather go for this angiotensin system inhibitors like ARNI or AC inhibitors or angiotensin 2 receptor blockers, followed by the beta blockers, because they do have the mortality benefit and would reduce the hospitalization.
Okay. Now, I'm talking about preserved ejection fraction. With preserved ejection fraction, reduced ejection fraction, you're absolutely spot on that they reduce. Unfortunately, the ARNI trials and the ACE inhibitor trials did not show a lot of benefit in with preserved ejection fraction. Even if the recent ARNI trials, they haven't been able to demonstrate a huge decrease. They were not as robust results as with reduced ejection fraction.
Some vasodilator can help.
Vasodilators can help, but I think beta blockers.
I think the flozins.
Yeah.
Absolutely right.
SGL2 inhibitor.
That is the drug which has to be considered as now a class, almost a class 2A indication. It is not a 1, but they have shown clearly to decrease heart failure with it. But the other evidence-based drug which has shown to be of significant help is the MRA. MRA has some good data with heart failure with preserved ejection fraction as well. So with an SGLT2 inhibitor, yes, that should be my first choice. And the second choice, before anything else, would be an MRA. So because MRA has shown that even with preserved ejection fraction, you decrease hospitalization rate. So this is a difficult subset of patients to deal with. There are very few drugs. The ACE inhibitors have, if you look at the CHARM preserved study, which was candesartan, which is an ARB in the preserved ejection, did not work. Beta blockers, unfortunately, did not work unless the patient was in atrial fibrillation, where you controlled the heart rate. But if you look at the and there are only 2 drugs which have shown to benefit them. One is the SGLT2 inhibitor, definitely the best of the lot, and next to it, I think the MRA. So we need to be aware of that in this group of patients. They are not a small group. 40% of heart failure patients are heart failure with preserved ejection fraction. I think basically it's a difficult area. And Dr. Moinak Gupta, are you there with us? Dr. Moinak Gupta?
Yes. Yes, sir.
So would you agree what we have discussed with preserved ejection fraction? Would you think of, after the diuresis and the rendering the patient euvolemic, the SGLT2 and the MRA should be your next choice of therapy?
Definitely, sir.
Okay.
But I have one doubt regarding this, because within a few months or so, within a year, we have come to know that ARNI can also be given, and ARNI can also be practiced in preserved ejection fraction group of heart failure patients.
Absolutely.
So,
Absolutely.
So, what is your opinion regarding that?
Let me put it.
I have no doubt regarding the first two points you have mentioned, but what Dr. Shayan said regarding the ARNI, because some thoughts came few months back or up to 1 year back, I think, regarding the use of ARNI in preserved ejection fraction.
Okay. Let me clarify that a little bit. Yes, I wouldn't say ARNI is not useful at all, but as a whole trial, the trial did not actually meet its significance. There was no significant benefit, but there was one group of patients who benefited, and that is ladies. Women with heart failure with preserved ejection fraction benefited more than men when ARNI was used. So in ladies, especially with heart failure with reduced ejection fraction, I think ARNI is something you would think of. But again, as a third step, the first two steps we have already decided should be an SGLT2 inhibitor as well as and then an MRA. Dr. Mondal, would you agree with that or disagree with that? This sort of this role of ARNI in preserved ejection fraction?
Yeah, as a woman, I would definitely agree to that.
I think so. The ladies for once did better.
Yeah.
So I think that is the subset which improved with ARNI. So we need to be aware. So let's move on. Now, this is basically the heart failure with reduced ejection fraction. And if you can see this is what is called the really fantastic four, or absolutely the foundational four therapies. Why do we call that foundational? Because of two things. One, they decrease hospitalization and they decrease mortality. So they are absolutely essential in reduced ejection fraction. One is an ACE inhibitor or an ARNI, that is your choice, a beta blocker, an MRA as well. Please understand that MRA is important here. And then, of course, the newer kid on the block is the SGLT2 inhibitor. So what would you do? You would first use a diuretics. You need to render the patient very, very asymptomatic with a diuretic. But the moment the diuretic has done its work and you have rendered it euvolemic, you should tend to actually decrease your loop diuretics, because that will help you to introduce these foundational four therapies. And I think that is something we miss. I think we are all aware of ARNI, we are all aware of beta blockers and SGLT2 inhibitors, but even in European and American study, only 30 to 35% of people with reduced ejection fraction are getting an MRA for two reasons. One, it's not so well discussed. Second, I think people are skeptical about their renal and hyperkalemic profile. So this is something we need to be aware of. So this is where I can show you. This is again a data from the ESC sites, which shows that if you have all the four therapies, ARNI, beta blocker, MRA, SGLT2, the benefit in heart failure with reduced ejection fraction is very, very significant. if you compare the other combinations where, say, an ARNI, a beta blocker, and an MRA is quite good actually, and an ACE inhibitor, beta blocker, and an MRA, again, quite good. But this is definitely the best, and that is what you need to be aware of. So in all patients with heart failure with reduced ejection fraction, you tend to decrease the mortality and hospitalization, and you need to be this. Now, this is an important slide, and I often like discussing this. And Dr. Ganguly has pointed out that we should be treating patient according to their need, not follow guidelines absolutely blindly, and you should patient-centric need. So this is basically an algorithm. I won't go into details of a patient profile. Say someone with a low blood pressure and an increased heart rate. So what you have a low blood pressure. An SGLT2 and an MRA is a drug which should be given, because as I said, we have discussed, Dr. Mondol has also agreed that an MRA and an SGLT2, they have the least hypotensive effect as compared to, say, an ARB, ARNI, or a beta blocker. And the drug we might consider if the patient is in sinus rhythm and the heart rate is still increased is ivabradine. Would you agree with that? Dr. Bishwanath Chakraborty, would you agree?
Yes, very much.
So this group of patients, I think this is where MRA has its advantage. I'm trying to show where the MRA has it's a little bit comfortable drug hemodynamically. Now, on the other hand, if you have a low blood pressure and a low heart rate, again, you can safely use the SGLT2 MRA inhibitor, but what needs to be modified is now the beta blockers, the ACE inhibitors, and maybe the diuretics. So this is where you need to modify or decrease the drug or suspend the drug. So if you look at all these subsets, if you see the SGLT2 and the MRA are nearly always there in all the subsets. Can you see this? So if you have someone with a high normal blood pressure and a high heart rate, again, an MRA and a beta blocker, all of them will work. If you have a patient with AF and normal blood pressure, again, you have an MRA and an SGLT2 apart from the other drug. So what it says that except for this group, where patient with CKD and an increased potassium, that is where you need to have a problem with a MRA. So if you look at all these subset, all these variable of clinical subset, the MRA is fairly universal. It's easy to use. It's only in this place where you need to have a little bit of reservation about use. And for all patient, ultimately, as Dr. Ganguly has said, you should try to introduce all the fantastic four: the MRA, SGLT2, an ARNI or an ACE inhibitor, and a beta blocker. And I think,
Dr. Ghosh, may I ask you a question?
Yes, sure.
Yeah, in the background of atrial fibrillation, how much you have prescribed digoxin? Now it is.
Yeah, I do prescribe digoxin, especially when the beta blockers can no longer be increased for heart rate control. See, heart rate control in chronic atrial fibrillation, the target heart rate should be between 60 and 110. That is the sweet spot. The range you need to maintain a patient resting heart rate between 60 and 110. Your first drug would be a beta blocker because it will help both the systolic dysfunction as well as control the heart rate. But on top of that, I think I do use lanoxin when I do not get a good control with the tolerated dose of beta blocker. Sometimes, you have to use it because the patient does not tolerate a high dose of beta blocker. And I still do use it, but as a second step, not as a first step. Okay.
Any role of verapamil?
No, verapamil in reduced ejection fraction is a contraindication. Okay, verapamil and diltiazem, if the ejection fraction is below 40%, do not use it. It increases mortality. So if you have to use rate controlling measures, I fully agree. Beta blocker should be your agent of choice initially, and then if you still need something else, lanoxin would be the second choice. Do not use verapamil. Do not use ivabradine. Ivabradine does not work in atrial fibrillation. Please understand
That
that.
is for sinus rhythm only.
It
In
works,
AF, you cannot use.
Use it. Absolutely right. And I think this is something which a lot of people are in the community are making a problem, that they are using ivabradine in atrial fibrillation to control the ventricular rate. Not there's absolutely, you will not get benefit that. Now,
Dr. Ghosh, just a minute. If there is any structural valvular disease,
yes,
in those cases, can we go for digoxin?
Yes, definitely. But again, absolutely fine. In fact, we have a very good data in rheumatic heart disease.
Yes.
That is what you are really. In rheumatic heart disease, you see someone with, say, mitral stenosis. Say, let's pick up an example. Someone with a tight mitral stenosis going into recurrent heart failure. You need to, the diastolic or the left atrial pressure is critically dependent on the heart rate. It's not a left ventricular failure. If you see in mitral stenosis, it's a left atrial failure. The pressure in the pulmonary veins is due to left atrial failure. The left atrium is unable to unload into the left ventricle, and there controlling the heart rate becomes very critical. And actually, I use digoxin much more frequently in this group of patients, but I do tend to use beta blocker still as my first agent of choice, because one thing which lanoxin does not do, that when these patients are walking or exercising and there is a sudden increase in the heart rate, even in patients with AF, the heart rate suddenly increases. Lanoxin cannot control that exercise-induced heart rate increase. There, you need a touch of beta blocker, but lanoxin controls resting heart rate very, very appropriately. And I think Dr. Shan Gupta, do you have, if you see the slide, do you think this is a reasonable way to tailor your treatment?
Yeah, absolutely.
I think this is a very good slide, and I think is something worth reading through from the ESC slides. What I want to point out is an SGLT2 MRA is nearly universal in all the patient groups except this group, CKD with potassium. And with all pre-discharge patients, you need to be on that. So let's progress on. So in what percentage do you use MRAs for your heart failure? I think we have discussed this quite frequently, but let me sort of ask Dr. Moinat Gupta. So realistically, what percentage of your patients are you able to use? I know you try to use it, but how many percentage are you able to use it in reality?
Since it is a cheap molecule,
yes.
So it is very much convenient for us to use in most of the patients in our clinical practice.
Yeah. So in your patients,
80% of the patients you can use.
Yes, absolutely, and I fully agree with that. And as I said, the only reservation is heart failure.
And use is also rational.
Use is rational, but I think for some reason it is underused. I think, would you agree that it's Dr. Bagh, is it a very underused molecule to an extent, the MRAs in heart failure? Dr. Bagh, can you hear us?
Yes, sir. Somehow it is used less due to probably some scarcity of hyperkalemia or other things. But it should be used for every patient if there is no strong contraindication like hyperkalemia or severely decreased renal function.
Yeah, I think that I agree that we should try to use it. And if we use it judicially, now all drugs have their side effects. So when do you consider MRAs in which, so what now we are timing, say suppose a patient with heart failure, acute heart failure, is just leaving the hospital and is going into the community. And the first visit is with you after he has been hospitalized. And he's already on an ARNI and a beta blocker. And where would you try to use the MRA straight away? How early would you try to use it? So, Dr. basically, Dr. Tanuka Mondol, would you like to say that in your practice, how frequent do you introduce it in the hospital itself before discharge, or do you wait for the first OPD visit?
I will say that I went through multiple studies today before this discussion was held. So I'm really sorry to say that we don't use it in the first go, but we should be using it in the first go. Today, when going through multiple studies, I came to know that within 3 to 7 days, if we use it, it has a significant benefit.
Absolutely.
And it decreases the mortality and the hospitalization by a significant rate. But when we use it, the time that we usually use it is after 7 days, and then it has got no utility, and the most of its the decrease in the hospitalization of the patient is not reduced significantly after 7 days. And that is what we usually practice till now. And the next time I'll not do it. I went through it once more and many times and through multiple studies, and I came to know within 7 days we should use it.
Okay, so Dr. Ganguly, how early are you comfortable using an MRA? So you have a heart failure patient who's already on an ARB or an ARNI and a beta blocker. So when would you introduce it? Before leaving the hospital, or in the first or the second hospital visit?
No, in the acute stage also, I would prefer starting MRA if there is no contraindication. And you told just before that it usually doesn't affect the blood pressure. So even at low blood pressure, we can start this MRA as soon as possible. But definitely in acute stage, we have to be extremely careful about the other factors, other comorbid diseases where we have to see the range of potassium especially, and also the EGFR. So in acute stage, considering if both these factors are stable or it's qualifying, then definitely I'll go for an early MRA.
Okay, I think this is like the way I started is basically the first drug to be used always is a beta blocker. Try to use a beta blocker in a heart failure, because that is the drug which will prevent sudden cardiac death because of its antiarrhythmic. And the next is basically a tailored treatment. If the blood pressure is low, I would use an MRA and an SGLT2 first, even before introducing the ACE inhibitor. On the other hand, if the blood pressure is on the higher side, I would use an ARB and the renal function is all right. I would use a ARNI with an MRA and take the SGLT2 inhibitor later. So it's a little bit of a jugglery according to your patient's profile. So let us discuss this aldosterone escape in congestive heart failure. And I think I would not go into the study. We have all read that there is what is called an ACE inhibitor resistance. When we use the ACE inhibitor, one of the ways that an ACE inhibitor works is by actually causing decreasing the levels of aldosterone. But there is an aldosterone escape after using an ACE inhibitor only without an MRA for a while. There is what we call a food positive feedback loop, and the aldosterone again comes back to the same pre-treatment level, and that is called an aldosterone escape phenomena. And with that, we can actually, the MRA helps a lot. So basically, this is again, we will quickly go through this. I don't think basically this is a small study from Bangladesh which shows a spironolactone and eplerenone on LV systolic dysfunction in chronic heart failure, which they have shown that eplerenone works a little better. I'm not 100% sure about this because the large international studies, the spironolactone in the RAILS trial and the FSS trial with eplerenone, they were equally powerful. You have to remember that eplerenone is a significantly more costly drug. So again, Dr. Shomunath Mukherjee, which of the group of patient would you, if you are using an MRA, which of the group of patient you would use an eplerenone and which group you use a spironolactone, or you don't differentiate at all?
No, I do prefer starting with spironolactone in all of my patients. But later on, if the patient comes with a complication of gynecomastia and all these problems, then significantly few patients I have seen with the spironolactone and in the loop diuretic like furosemide, they came with a gynecomastia. Then I switched over to torsemide and eplerenone. So the symptoms are decreased and the patient was much relieved.
Yeah. Come, please go ahead.
Yeah. So otherwise, with the cost factor and all the other medication cost factor, I don't differentiate between these two. First, we'll go for spironolactone, and if it doesn't tolerate, then we'll go for epinephrine.
No, I think this is something which we are fully aware of. And Dr. Chaudhary, Bodhisattva Chaudhary, do you have any specific patient profiles that you would prefer eplerenone or you would prefer spironolactone?
Actually, for me, in my personal experience, both of them are almost equally efficient. So I don't personally differentiate not much. But one thing I have seen in patient with ejection fraction around, let's say, 40 to 45 or EGFR just above 30, not less than just above 30. In those patients, spironolactone has a more chance, more propensity of causing hyperkalemia than eplerenone. I don't know whether there is study to prove it or not. This is just my personal experience. In those patients which are bed crisis, I have actually I use eplerenone more than spironolactone.
Okay. So that's a fair. I think both are very, very equivalent molecules, and I think there are special group. Doctor, this is a specific question for which group of Dr. Mondal? Do you have any specific areas where you prefer one molecule over the other?
I would, in male patients, I would prefer eplerenone than spironolactone to avoid any kind of gynecomastia and everything. Yeah. And moreover, in a hospital setup like ours, the one we have in supply with us, usually we give the one that we have in our hand. Yeah, but in our clinics, definitely I will prefer eplerenone.
Okay, I think basically spironolactone and eplerenone, from the heart failure point of view, both are equally good. One group which we have always mentioned is gynecomastia. Please understand the other group also, that in women of the reproductive age group, spironolactone does causes a lot of menstrual cycle problems, because it's an active estrogen mimicry molecule. So be aware of that. We do have these patients coming with, say for example, postpartum cardiomyopathy, young women coming with heart failure. And there, sometimes if you use spironolactone, you need to be aware that there is a hormonal imbalance, and that can be somewhat mitigated by using eplerenone. But the main advantage of spironolactone is obviously the cost, because this is a chronic molecule. You need to be aware of what the cost implications are. So this is basically a algorithm where how would you sort of use spironolactone or dose inhibition. I do not agree with all of them, but here let me start from the bottom. Everyone agrees that if you have a hyperkalemia above 6 or a GFR below 30, I think we cannot use it. So suppose, say, Dr. Gupta, Mainak Gupta, if you have someone whom you were using eplerenone or spironolactone, and suddenly the GFR falls, and the potassium becomes, say, 5.8, 5.9, what would you do? The GFR comes below 30. What would you do?
We often come across this type of patients, especially in the stage 4, 5 CKD patients and frail elderly patients with heart failure, etc. So what we can do, we can withdraw this, or we can reduce the dose of the molecule. Either reduce, or if it is more than 6, we need to treat first. We need to bring down the potassium first and reduce the dose, or temporarily withdraw the molecule.
Would you think of reintroducing the molecule? So someone who's had a heart failure episode, and you were treating him on spironolactone, and then he goes, his the creatinine becomes 3, and his GFR calculated is below 30, and his potassium becomes, say, 5.8. Would you, so you, as you said, you would stop the molecule. All of us would stop the molecule. Okay. would you think of reintroducing it, or would you not consider not using it at all? And this is basically a discussion which we can have among everyone. So what would you do?
We can reintroduce if if the patient is stage 5 CKD, if the patient to be put on any dialysis like procedure or anything, we can reintroduce. Otherwise, very close monitoring is needed so that potassium is not rise again.
Okay, Dr. Ganguly, what is your opinion about this? So someone who's deteriorated renal function with hyperkalemia on an MRA, you have stopped the molecule. Would you never consider using it again, or would you give it a trial again later? What would your thought process be?
Maybe if heart failure is very significant, I might, after reduction of potassium, I might give her one more trial. But if it again goes up in another 24 to 48 hours, I would rather ask an opinion from a nephrologist whether I should start it again or not.
Yeah, I think that's a very wise way of approaching it. It's a very difficult scenario, but you have to understand that renal dysfunction, what we call the cardiorenal syndromes now, that now we understand that we initially thought that heart failure and kidneys are very linked together, and the deterioration of kidney function in heart failure was always due to lack of forward flow into the kidneys. There was hypoperfusion of the kidneys, and especially that was exaggerated by the hypotensive drugs which we use to do money. But now we understand that actually 40% is also on the venous congestion. So if you have a very high venous pressure, that also decreases the GFR, because the efferent tubule is dependent on the backflow. So if you relieve the venous pressure by diuresis or whatever, actually the kidney function does improve significantly. So I think I would agree with Dr. Ganguly that I would not call it a day. I would actually try to optimize the heart failure even better, and then give it one more trial and see whether they are holding, because it's a mortality preventing drug. The dose schedule is fairly simple, and I for one do not use very high doses of either spironolactone or eplerenone. I usually keep it for most of my patients to 25. Anyone using very high doses of spironolactone, say 100 milligrams or 50 milligrams even in heart
mostly
failure?
In liver disease, I think.
Yeah, I think, yes, absolutely right. If you have ascites, the volume of distribution of spironolactone actually gets hugely increased. And there, I think, if you have ascites, even with congestive heart failure, if you have ascites, the volume of distribution of the drug increases, and that is where you would use increased. With all the other trials with heart failure, I think 25 milligram dose is more or less what we would say an adequate dose. Would you agree with that? I think Dr. Chakraborty, would you agree with that?
My view is that after controlling the hyperkalemia, we can start eplerenone, because the half-life of eplerenone is less than spironolactone. Maybe 25 milligram once daily with a potassium binder, we can start if we think that it is absolutely necessary.
Absolutely, yes. It is a, if you can use it, obviously it is significant to use it, but you have to be very careful.
Eplerenone is preferable than spironolactone because of the half-life.
Okay. Dr. Gupta, what is your opinion about this? Two opinions. One, whether you would restart after an initial hyperkalemic episode or deterioration of renal function, and B, would you use these increased doses of either of the molecules beyond 25 milligrams in your standard heart failure patients?
I would like to continue with the standard dosage of 25 milligram per day. And if it causes hyperkalemia, then we should be very cautious. We should actually stop the molecule once the patient's renal functions, they do improve. We can actually give a try. However, even after that, if the patient cannot tolerate the medicine, then unfortunately, I think we have to stop the medication.
I think this is a reasonable way. I don't personally in my practice, my usual dose is 25 milligrams. I don't try to achieve it, except for, as Dr. Ganguly has pointed out, in patients with ascites, with liver disease, or even in severe heart failure, you have ascites even without liver disease. So in that case, the volume of drug distribution increases. There you would use a higher dose of spironolactone. So as I said, this is exactly the question. What is the preferred dose? How is the dose titration going to continue? So I think Dr. Bagh, would you think a higher dose is of significant help in heart failure? Stable heart failure, heart failure? Dr. Bagh, are you there?
Pardon, sir?
Hi. What is your preferred dose of eplerenone and spironolactone in heart failure, usual heart failure, not someone with ascites?
25 milligram per day, sir.
Come again, I didn't hear that. 25?
25.
Okay, so I think I think your opinion is more or less similar to all of us. And in that case, the question of titrating the dose is a. Sometimes if you have borderline hyperkalemia, say potassium of 5 to say 5.6 or 5.7, sometimes it's useful to use it on alternate days. You don't use it daily. Do you think that's something you could think of, Dr. Mukherjee, Shomunath Mukherjee?
I think he has left.
Oh, he's left. Okay, fine. So basically, I think we will go on to the next one. This is basically MRA-related hyperkalemia, and I think we need to be aware of that. There's nothing on it. We have discussed this. So again, what patient of MRA develop hyperkalemia and do they require discontinuation? Again, we have discussed this quite extensively. And how are the patients managed? I think we have discussed this again quite nicely in my previous talk. So this is basically an eplerenone in heart failure in acute myocardial infarction. So this is a little different topic. You've had a patient who's come with an acute MI, and you would actually consider, would you consider using, and they have heart failure episode, would you consider using eplerenone or a spironolactone in this group of patients? Can I start with Dr. Tanuka? Hello.
Yeah, sure. Sorry, I was muted. Actually, this is the part which I was talking about before.
Yeah.
That in case of AMI, we have to we can reduce the hospitalization by initiating MRA as soon as possible.
Yeah.
So that
especially in the setting of an acute MI. Hello.
Yes. Hello.
Am
I audible?
Yeah, you are audible.
Okay. Yeah, the initiation as early as it is possible to reduce the heart failure, because we commonly give ACEIs and ARBs in the first go and beta blockers, but we should also think about MRAs over here, which we usually do not prescribe in our setting, but it should be prescribed to decrease the hospitalization in future from the LV systolic dysfunction. It can reduce it.
Dr. Moinak Gupta, would you agree with this, that in patients coming with acute MI and with LV systolic dysfunction or even borderline heart failure, would you consider using MRA fairly early in the disease during the hospitalization?
Definitely, sir.
Okay.
Use of MRA in as early as possible in the hospital setting could bring down the repeat hospitalization rate. And probably I have seen, I don't know exactly, but can you give me a better opinion? Eplerenone is somewhat better used in post-MI patients, I have seen.
Yeah.
Comparison to spironolactone.
Yeah, I think because this
cardiologists used eplerenone rather more.
I think this is the basis of this trial, EFSUS trial, because the spironolactone trial in acute MI is not so big. This EFSUS trial was eplerenone in acute MI. So this setting, definitely you would use eplerenone fairly early in the disease, probably in the hospitalization, and actually, so what do you think, Dr. Ganguly? What do you think is the main advantage of using eplerenone early in acute MI patients with heart failure?
I don't have that much of experience in using eplerenone in my AMI patients, because you know most of the patients in acute MI, they, if it is feasible, then go for intervention. In those cases, I'm not sure whether eplerenone will help in the pre-lab session or in the post-lab. I don't have that much of experience.
Now, I think let's discuss it. The reason why you would use it is this. Can you, if I'm pointing it with my arrow, sudden cardiac death decreases by 34%. So any molecule which decreases heart failure hospitalization takes a little time. But if you have some drug which prevents sudden cardiac death in this group, acute MI or acute heart failure, it's worth using very, very early. Beta blocker does that very much. And so we introduce beta blocker in almost all acute MI patients, isn't it? And the reason we use it very early is because it has a propensity to decrease arrhythmia. Now, eplerenone did decrease sudden cardiac death, and that is why we need to introduce is failure, but not in all acute patients, not with someone who's had a small MI and the LV function is say 45%. And there's no heart failure. This is typically for anterior MI with some amount of LV dysfunction or a large inferior posterior MI with LV dysfunction. Dr. Ganguly, I agree with you that even if you do an angioplasty, which we do in Apollo, we do nearly 100% primary angioplasties. We do not thrombolize anymore. But even if you do, once you put in a stent, you have to remember the heart function does not improve straight away. It takes a little while, almost a month, for it to come in, because there's a lot of stunning, there's a lot of hibernation coming on. So opening up the epicardial artery will benefit the patient and will benefit that immediately as well by decreasing arrhythmia. But for the full benefit of opening up the artery, it only comes after a month. So if someone in the meantime, even if you had put in a stent with primary plasty and they went into heart failure, it's not an uncommon scenario. I think using eplerenone is absolutely reasonable. A beta blocker in eplerenone is absolutely reasonable. I think this is something the data would tell us. So let us move on to the next one. This is basically in the heart failure with post-MI patient, where eplerenone earlier and we go through it. In clinical, again, I think we have discussed this. We initiated, so we'll skip on that. In chronic heart failure with reduced ejection fraction, I think the recommendation is that you need to get all these 4 therapies: inhibitor, RT, beta blockers, MRA, this SGLT2 within the first month of diagnosis. How feasible are you, basically, Dr. Bagh, do you try this within all these 4 drugs within 1 month of diagnosis of chronic with reduced ejection fraction?
With reduced ejection fraction?
With reduced, this we are talking about reduced ejection fraction here. So these are the four molecules. Yeah,
first diuretics, then SGLT2 inhibitor or MRA, and followed by beta blocker or NI.
Okay. Any other sequence? Basically, Dr. Shayan Gupta, would you think of this kind of a sequence, or would you tailor the sequence according to the hemodynamics of the patient?
First of all, if for the decongestive action, I would rather go for the diuretics, and thereby, if the patient is actually maintaining a decent hemodynamic parameter, then beta blockers, renin-angiotensin system inhibitors, and these should be the primary pharmacological treatment. And if not controlled. If the heart failure is not adequately controlled, despite this optimal medical therapy, then I would go for MRA and SGLT2 inhibitors.
Okay. I think what it means that all these molecules are very powerful, and actually the improvement, as Dr. Tanuka has repeatedly mentioned, that all the benefit becomes fairly early after introduction. Even the curve starts separating with all these studies, in all the studies with beta blockers, with ARNI, with MRA, with SGLT2, within the first months of introduction. So the recommendation is that you need to have them on board within at least 1 month. It's not necessary that you have to go to the highest dose of each molecule before thinking of the other molecule. It is better to start a group in small, reduce all the 4 groups. I think that is a reasonable way. Basically, at what stage of heart failure diuretics and MRAs are necessary? I think this is basically more or less choice what we need to advise to CIPLA, that if we are using a diuretic to control the heart failure symptoms and an MRA to introduce, what is the role of combination therapy? Chaudhary, Bodhisattva Chaudhary, if you are there.
Yes, sir.
So, how do you use combination therapies, or you use the molecules separately? You prefer to use the molecules separately, a loop diuretic and an MRA?
Sir, I think it again varies from patient to patient. In some patient, I have used it separately, and some patient I have used it as a combination. If the patient has a significant fluid overload, diuretic would be my preferred choice. And depending on the other renal and potassium parameters, I will decide whether I want to add MRA or not. If everything is fine, if the kidney parameters are okay, potassium is okay, then I'll definitely add MRA to the existing diuretic. And if the patient is not on fluid overload, there is heart failure, then I would start with only MRA rather than going for diuretic.
I think I think it's a tailored therapy. Sometimes, yes, if you're not at, Dr. Gupta, would you agree with what was suggested, Dr. Baina Gupta?
Yes, sir, definitely.
I think it's a tailored therapy.
Treatment should be individualized depending upon the patient's hemodynamics, renal and electrolyte status.
Yes, I think I fully agree that you might want to start separately, because your diuretic dose has to be variable as the patient is becoming euvolemic. You want to decrease the diuretics, but not the MRA. The MRA you want to stay at least at 25 milligrams. So the diuretics, so I would tend to use it separately initially, but on a long-term basis, suppose they become, say someone becomes fixed on torsemide of 5 milligrams and spironolactone of 25, in that case, a combination therapy to simplify compliance is worthwhile thinking of. I think that is the way to think. So this is basically the last slide in our discussion today. It was a very good discussion. So in your practice, any other indication apart from heart failure with MRA is used? Anyone would like to sort of answer that? Maybe Dr. Bagh? Any other indication? Forget about if you have discussed heart failure. So apart from heart failure, well, else?
Sir, refractory hypokalemia.
That is very good. Absolutely, this is something. Anyone else? Dr. Tanuka? Any area where you would use MRA beyond heart failure?
Of course, in liver disease with ascites.
Yeah, that's one thing. Dr. Shayan Gupta, any other indication you think of?
No, I'm not aware. I mean, we have used this in cirrhosis patient where there is secondary hyperaldosteronism.
That is we are covered with CLD. That is outside. Dr. Ganguly, any area you would think of? I have one area where I use. I'll come out with it. Is resistant hypertension.
Yes.
I think resistant hypertension. And the third molecule, you have a ACE inhibitor, a clothalidone, and calcium channel CCB on, and you're still not controlling the blood pressure. And using an MRA sometimes actually becomes very, very useful. And that is because of what we had discussed a little bit with is the aldosterone escape phenomena with ACE inhibitors. So in stage 3, in difficult hypertension, as the third line of choice, after you have exhausted your choice of an ARB ACE inhibitors, a clothalidone, or an hydrochlorothiazide, and a CCB like amlodipine, you would think of, especially if the potassium and the renal function is used. I have often got a lot of benefit by introducing an MRA. Sometimes that has given me an edge to the treatment. So the last question, what scientific initiative would you suggest to CIPLA for increasing awareness of CPs? I think I was very pleasantly surprised that all of us in this discussion group are aware of the benefits of MRA in heart failure, and that was a very, very pleasant surprise. And I think all of us agreed that we need to treat this molecule, use this molecule fairly early in the disease. So any suggestions from anybody? It's an open discussion now. So if anyone
what is CP among the CPs? What does it mean?
You got
clinical practitioner.
Probably clinical practitioners or community
clinical practitioner.
Okay, clinical practitioner. Okay.
Yes.
So I think any suggestions from anyone? This is an open house now. So,
they should start initiating this sort of program, because today sitting here for 1.5 hours, I really feel that we are so much enriched with our knowledge. Although it's known to everyone, but in this sort of forum, we can easily ask even a silly question, or we can utter some mistakes also, but we can take away the beneficial part of such a program. So I can suggest that this sort of scientific initiative they can take.
I think very well said. Basically, I think we are all practicing clinicians, and sometimes theoretical bookish medicine is not so relevant to us than discussing among colleagues in groups and forums like that, and discussing the pros and cons. It's not as simple. So, you have a trial come out and everyone says, okay, let's use it. It's not simple. When you use it in the community, then you understand the advantage and also the disadvantage of using this therapy. So I think it has been a very good discussion, and I was really, really happy to know that we are aware of it. And I think this is the way to go forward. So I'll stop sharing my slide and I'll hand it over to the CIPLA group, or if anyone has to.
Dr. Ghosh,
yes, tell me.
Thank you very much for conducting such a nice session.
Okay, I hope it was.
Thank you so much. Thank you so much.
I hope it was useful to all of you.
It's extremely useful.
Extremely useful.
Extremely useful and extremely
really useful.
Set of discussions were done. I got to know everyone's opinion regarding this MRAs. It was very nice. It was very nice.
Thank you. So
good night.
Okay.
Thank you, sir. Thank you.
Okay. So Somadev, if you can say the vote of thanks.
Sanjay here, sir. Sanjay here.
Oh, Sanjay. Sanjay.
It was really a wonderful and very informative session. And I would like to thank our moderator, sir, Dr. Debasis Ghosh, sir, and all the panel doctors. Thank you for your time and efforts.
Okay.
So stay safe and take care, everyone. Good night, sir.
Okay. Good night. Thank you.
Good night. Thank you, sir. Thank you, sir.
Good night. Thank you.